Hello, Clinic Review family. Today I'm talking about hysterectomy, a relatively common intervention that you need to know about for your Nclex. So let's go ahead and get started. Hello, my friends. It's Dr. Sharon with Clinic Reviews, the home of the very best Nclex review in the entire universe, in my opinion. Today we're talking about hysterectomy, which comes from the Blue Book. The Blue Book is what I'm pointing to right over my shoulder there. You can get it on Amazon. You can just order it. Just type in Clinic Blue Book and it'll pop up. And if you are outside the part of the world where Amazon delivers, then you can download the Blue Book app at clinicreviews.com. So you know that Clinic Reviews is primarily an Nclex prep business, and we are part of the greater Clinic Review organization. We have this channel to provide information about things that we don't teach as part of the Clinic Review. The Clinic Review is a 21 plus hours of Nclex prep taught by the GOAT himself, Mark Klimek. I strongly, highly recommend it. It's very, very good. Mark Klimek has taught me everything I know about anything related to nursing. And we also have a streaming service and we have small group tutoring. I don't do individualized tutoring anymore. We do small group tutoring. You can buy a monthly package, and I teach 2 of the 4 tutoring sessions. So today we're going to be doing hysterectomy. The Blue Book contains information you need to know for the Nclex. So people say, what do I have to know, Dr. Sharon? And I say, got to know the Blue Book. So that's something you need to know. Hysterectomy is one of the topics I have been doing over the last months. I have been doing various topics in the Blue Book. You can go to the playlist of Blue Book, or you can do the breakdown of the different Blue Book topics. All right, let's go ahead and get started. We won't keep talking about that. All right, during a pre-operative teaching for a vaginal hysterectomy, which client statement indicates correct understanding of deep breathing exercises? So you can have a vaginal hysterectomy where they go through the vagina. You can have an abdominal hysterectomy where they cut in through the abdomen. They both will have risks for bleeding. They both will have many of the same risks, but one you can just recover from a little bit more quickly. So it's still a surgery, whether it's vaginal or abdominal. So you're still going to have to do deep coughing and deep breathing. This is specific to deep breathing. I'll take shallow breaths to avoid stressing the incision. I should cough forcefully every 30 minutes after surgery. I'll inhale deeply, hold for 3 seconds, and exhale slowly 10 times each hour using the incentive spirometer. Could increase my bleeding risk. So this is specific to deep breathing. It's not about coughing. So deep breathing has to do with taking in 10 deep breaths every hour. And it's not about exhaling, it's about inhaling. And the coughing, if normally taking deep breaths will stimulate a cough. If not, you can do a cough at the end of the 10 deep breaths. But the deep breathing specifically is described in option C. The nurse is caring for a client 4 hours after laparoscopic hysterectomy. So they went in still through the abdomen, but they did it laparoscopically. So they're just going to have 4 small incisions in the abdomen that are going to be closed, usually with steri strips or maybe a Band-Aid. Which assessment finding warrants the most immediate intervention? So the most immediate intervention should always be warranted by the unexpected finding. Shoulder tip pain rated 6 out of 10, 20 ml urine output in the past hour, abdominal distension with hypoactive bowel sounds, small serosanguinous drainage on the incision, dressing. Okay, 4 hours, they're still in the post-op period. They just had incisions made into their abdomen. I would expect pain. Now you may say, well, Sharon, what about the shoulder? Well, what happens when they do a abdominal laparoscopic surgery is they blow air into the abdomen to distend it so that they can see better. And that actually causes shoulder pain. So that's actually expected. 20 mils urine output in the past hour is low. They should have 30 mils at least an hour. So that's too low. So I'm concerned about B. That's unexpected. Abdominal distension with hypoactive bowel sounds. Well, they had anesthesia, which causes hypoactive bowel sounds. It decreases peristalsis. So I'm not surprised by the hypoactive bowel sounds, and I'm not surprised by the abdominal distension because they blew all that air into the peritoneal cavity. So C is expected. Small serosanguinous drainage on the incision dressing. Serosanguinous is fine. That's not at all surprising. So the only one that is unexpected is 20 mils urine out in the last hour. Which discharge instruction is priority for a client after a vaginal hysterectomy? Increase vitamin C intake to promote healing. Take tub baths instead of showers to keep the incision clean. You may resume sexual intercourse when you feel ready. Avoid lifting anything heavier than a gallon of milk for 4 to 6 weeks. So unless they tell you otherwise, or unless you know for sure otherwise, generally after any surgery, I'm not talking about a diagnostic test, I'm talking about actual surgery, we usually recommend post-op restrictions for 4 to 6 weeks. Now, those post-op restrictions involve heavy lifting, they involve driving. Depending on the location of the incision, it may involve intercourse, it may involve returning to work, and so forth. So typically, post-op restrictions last 4 to 6 weeks. So what is a priority for a client after vaginal hysterectomy? So when it says what's a priority, it means if you're going to teach anything, you got to teach this one thing. Increase vitamin C intake to promote healing. Well, that's okay, but that's certainly, there's no evidence. Nclex doesn't love those kinds of answers because there's not a lot of evidence for it. There may be some descriptive studies, but not a lot of high level evidence. So they don't love answers like that. Take tub baths instead of showers to keep the incision clean. You really, after any surgery, you shouldn't be taking tub baths for 4 to 6 weeks because you got to let stuff heal. So B is out. You may resume sexual intercourse when you feel ready. Maybe, but I would prefer it, say 4 to 6 weeks. So that's not a great answer. Avoid lifting anything heavier than a gallon of milk for 4 to 6 weeks. So I like D best. Heavy lifting, there's always a risk of herniating any incision or causing bleeding or tearing to any incision for 4 to 6 weeks after surgery. And we always say after any surgery, don't lift anything heavier than a gallon of milk or 5 pounds or a gallon of milk for 4 to 6 weeks. A client phones the clinic 3 days after discharge following total abdominal hysterectomy. A total abdominal hysterectomy involves removing the uterus and the cervix. If they have their ovaries removed, they call that an oophorectomy. So they would say an total abdominal hysterectomy with oophorectomy. All right. So 3 days after discharge following total abdominal hysterectomy, which symptom requires the nurse to advise the client to come in today. So that means which is unexpected or life-threatening or unexpected. We'll leave it at that. Let's see what we have. Pink vaginal spotting on tissue, low-grade evening temperature of 99.4, new onset calf pain with dorsiflexion of the foot, mild fatigue that improves with rest. All right, so 3 days after discharge from total abdominal hysterectomy. So they had a major abdominal surgery, so I expect them to be tired. That's very common, so I'm going to cross off D, that is expected. Actually, body temperature goes up in the afternoon. That's expected, and it's not even outside normal limits. So 99.4, so B is fine. Pink vaginal spotting on the tissue, that's expected. They have had major surgery and for some bleeding from the incision to come out through the vagina is fine. It's just pink. They're not hemorrhaging out or anything like that. So I'm fine with A, B, and D. New onset, anything that says new onset, I'm concerned about. Okay, that's a key red flag word that tells me it's unexpected. So it's a changing assessment. New onset calf pain. DVT is a risk factor after hysterectomy. It's something they have to watch for. You teach them to watch for that. And so I'm concerned about that. They need to be seen today. A 38-year-old client with endometriosis asked why her surgeon recommends laparoscopic hysterectomy instead of abdominal. The nurse's best response is, you will have a shorter hospital stay and quicker recovery. The laparoscopic approach eliminates the risk of infection and avoids the need for general anesthesia. It is less expensive than the abdominal procedure. All right, why do laparoscopic instead of open abdominal? All right, so that's just, you're doing 4 little incisions to remove it rather than a big abdominal incision. I don't know what the cost is. I would never pick D. I'm sure there's a lot of different factors that go into the cost. So I'm not picking D. Avoids the need for general anesthesia. Both of them are major surgeries. Both of them are major abdominal surgeries. They both require general anesthesia. You're not getting your uterus removed under a local anesthesia, trust me. The laparoscopic approach eliminates the risk of infection. No, you're still making incisions. You're still breaking skin, introducing things into the body that are not supposed to be there. So absolutely, it still has a risk for infection. You'll have a shorter hospital stay and quicker recovery. That is the reason they would do it. They would do laparoscopic rather than open. And that's just because you have 4 very small incisions rather than one big abdominal incision. The nurse is preparing discharge teaching for a client who had a total hysterectomy with bilateral salpingo-oophorectomy. There it is. Total hysterectomy, sorry. And they removed the ovaries. Which topics are essential? Signs of surgical site infection, hormone replacement therapy options, monthly breast self-exam, technique, timing of future pap smears, importance of high protein diet until the next follow-up. Okay, so they've had their cervix and their uterus removed and their ovaries are what secrete all the hormones. So signs of surgical site infection is essential after total hysterectomy and bilateral salpingo-oophorectomy. That is true. So it doesn't say exactly where the surgical incisions are. It doesn't say if it's laparoscopic or open abdominal, but it doesn't really matter because they did surgery. They cut into the skin. You're going to have to watch for infection. Hormone replacement therapy options are essential to discuss after bilateral salpingo-oophorectomy. That is true. They don't have to do hormone replacement, but they should at least be discussed because it's going to throw them right into menopause. And they may want to take estrogen for a while, depending on their risk for breast cancer and so forth. So there you go. So you need to do that. Monthly breast self-exams are essential after total abdominal hysterectomy and bilateral salpingo-oophorectomy. So there is a need to still do monthly self-breast exams. So monthly self-breast exams are important for all women, no matter the age or the menopausal state or anything. Like, you can get breast cancer at any time, at any age, and that's important to do. And just because she's had a hysterectomy doesn't mean she should stop doing breast exams. So that actually is important. This is a good time to talk about that. The timing of future pap smears is essential to talk about after total hysterectomy. That's actually not true. If they take the cervix out, there's nothing there to examine. So there is no need for pap smears after total hysterectomy and bilateral salpingo-oophorectomy. There's nothing left to look at. Importance of high protein diet until next follow-up is essential after total hysterectomy and bilateral salpingo-oophorectomy. So it is important that they ingest protein, and it's important that they have adequate caloric intake, but they don't have to do high protein. That's not essential. And the word essential is what's kind of guiding me here, because they have to have adequate caloric intake, but they don't have to have a high protein diet. So those are the correct answers. 12 hours after an abdominal hysterectomy, the client's hemoglobin has fallen from 12 pre-op to 9. That's a big drop. Blood pressure is 102/64, which is within normal limits, but it's on the lower side of within normal limits. And they're tachycardic, and the abdominal dressing is dry. Which complication is the nurse most concerned about? So I'm not surprised by a slight drop in hemoglobin. Like, if it had gone from 12 to 11.5, I would have been okay with that. There would have been a couple reasons. There is bleeding during the surgery, so that doesn't surprise me. And they could be hemodiluted if we gave them a lot of IV fluids. So a slight drop in hemoglobin doesn't bother me, but they have a big drop in hemoglobin and they're tachycardic, which tells me there's something else going on. I'm concerned about bleeding here is what I'm concerned about. And you might say, well, their abdominal dressing is dry. Well, it could be internal. So internal pelvic hemorrhage, fluid volume overload, paralytic ileus, or bladder distension. So probably you all know it's internal pelvic hemorrhage. Fluid volume overload, we would see edema, crackles in the lungs, that kind of thing. We would not see a low blood pressure and tachycardia. Fluid volume overload, I just said that. Paralytic ileus, they would say absent bowel sounds, nausea, maybe some projectile vomiting. So that's a big no. Bladder distension, they don't even give me a bladder assessment. So there's no way I can say bladder distension. A client with a history of coronary artery disease and atrial fibrillation who is on warfarin is scheduled for elective hysterectomy. Which pre-op order should the nurse question? Now, we question orders that are harmful to the patient. We clarify orders that are written incorrectly, but we question orders that are harmful. Remember that distinction. If they ask you to clarify an order, you look for the one that's written incorrectly. If it's clarification or if it's questioning, you say which one could harm the patient. Hold warfarin 5 days before surgery. Could that harm the patient? Well, you might be concerned about the AFib, but they can't have surgery while they're on warfarin. So that's an okay order. I'm not worried about that order. Start enoxaparin 48 hours after stopping warfarin. Well, there you go. I like that one. So we can do Lovenox, which has a short half-life if we're stopping warfarin. So I like B. Administer vitamin K 2 milligrams orally the night before surgery. So vitamin K is the antidote for warfarin. Well, if they're on Lovenox, that should be fine. And we need to get their INR down. INR is what we look at for bleeding times when they're on warfarin. Maintain an INR between 2 and 3 on the day of surgery. Well, an INR between 2 and 3 is a therapeutic level for warfarin, which means they're likely to bleed out if they're having INR between 2 and 3. So D is the one I'm going to question because I'm like, why? They can't have surgery if their INR is between 2 and 3. What in the world is this all about? Did you miswrite it? What happened? What's going on here? This is not a good order. 4 days post-op, a client develops abdominal cramping, absent bowel sounds, and 300 mils of bilious emesis. Which provider order should the nurse implement first? Administer ondansetron IV, insert a nasogastric tube to low suction, encourage ambulation in the hallway, provide sips of clear liquids as tolerated. All right, so here we have multiple symptoms in the question. We have to see which orders address which symptoms. So let's do that first. Ondansetron, what will that address? Well, that might address the emesis. Specifically, we tend to give ondansetron for nausea, but it's maybe could address the emesis. Insert a nasogastric tube to low wall suction. That addresses actually absent bowel sounds and emesis. Encourage ambulation in the hallway. That might address the abdominal cramping, maybe. Certainly isn't going to address the other stuff. That doesn't even seem appropriate. We encourage ambulation for someone who is constipated, but this person probably has a paralytic ileus. Okay, that means because you don't just start throwing up because you're constipated. You start throwing up because you've got a bowel obstruction or paralytic ileus, which means you've got some kind of a paralyzed portion of the bowel that nothing can go past, and so it starts coming up the other way. So I'm not really too crazy about ambulation. This patient seems unstable to me. Provide sips of clear liquids as tolerated. That's not good for any of those things. They're vomiting. So I'm crossing off C and D. So the question is, which would I do first? Well, I want to address the physiological problem first. So the nasogastric tube to low suction addresses absent bowel sounds and the emesis, whereas the ondansetron might address the emesis. It is more likely to address any nausea that they feel they have. So I really have to do the nasogastric tube to low wall suction. A client who underwent total hysterectomy with bilateral oophorectomy asks when hot flashes will start. The nurse explains they're most likely to appear immediately in the recovery room within the first few days, 2 weeks after surgery. Days to weeks postoperatively, about 6 months after surgery. Only if hormone replacement therapy is initiated. Well, they just removed their ovaries, which is going to throw them into menopause pretty much immediately, but not in the recovery room. Okay, that's a little extreme. Not the recovery room, but days afterwards, 2 weeks. Yeah, for sure. Which laboratory value on postoperative day 2 abdominal hysterectomy after abdominal hysterectomy would require notifying the surgeon? White count 13,000, hematocrit 34%, platelets 90,000, serum sodium 134. So the white count is high, the hematocrit slightly low, the platelets are very low, the serum sodium is slightly low. So which one is unexpected? Because they're all abnormal. So they just had surgery. They just cut into the body, and the immune system interprets that as a negative action. And so the immune system has a response. So the white count going up slightly is actually expected. And high end of normal is 11,000. So going up to 13,000 is a fairly mild immune response, and it's totally expected. Hematocrit is 3 times the hemoglobin. So hemoglobin is 12 to 18. And hematocrit then is 12 times 3 is 36, 18 times 3 is 54. So normal hematocrit is 36 to 54. Now, hematocrit is a percentage. So it generally goes up and down with hemoglobin, but it can also go up and down with dilution or hyperconcentration if they lose a lot of serum or something like that. In this case, low end of normal is 36%. This is 34%. That's actually pretty expected. They would have lost surgery. They would have lost blood during surgery. So if it's 34%, that probably means the hemoglobin is like 11.5 or 11.25 or something like that. So that's okay. That's an expected drop after surgery. Platelets 90,000. So normal is 150 to 400,000. So that's a very low platelet count. And it does put them at risk for bleeding. So I am quite concerned about the platelet count after surgery. Serum sodium 135 to 145 is normal. It's just slightly low. It could be from dilution. It could be because we're giving them a ton of fluids post-operatively, or it could be just low for a little while. I'm not that concerned about it. The body can tolerate really big fluctuations in sodium. So I'm not that concerned about it. Certainly not compared to the platelets. So the platelets are very low. I'm worried about bleeding. A client expresses concern about body image after hysterectomy. Which response by the nurse is best? Tell me more about how losing your uterus makes you feel. At least the uterus isn't visible, so nobody will know. Most women feel fine once the incision heals. You can ask your doctor about cosmetic surgery if needed. All right, so she's expressing concern about her body image, and this is, what's your best response? Whenever they ask you a best response question as it relates to therapeutic communication, because this is a therapeutic communication question, right? She expresses concern, and then you respond. The reason I'm going over this is a lot of people struggle with therapeutic communication questions, and that's because sometimes the right answer is not something they would say. And so my response to that is, it doesn't have to be something you would say. It just has to be something that is consistent with the rule of therapeutic communication. And the rules, there's 2 rules of therapeutic communication. Address it immediately if you can. Number 2, encourage them to talk. So you want to pick an answer that has the immediacy thing covered. So don't say, oh, we'll talk about it later, right? You want to talk about it now. And you want to encourage them to talk. So which answer encourages them to talk and addresses it now? Tell me more about how losing your uterus makes you feel. Well, that's encouraging her to talk. You might go, I'd never say that. Well, maybe I wouldn't either. Maybe I'd just go, tell me more about how you feel, or tell me why you're saying that. Maybe I would, but A meets the 2 criteria. It's immediate, and it encourages her to talk. At least the uterus isn't visible, so nobody will know. That's just cutting her off. That's like saying, don't worry about it. Most women feel fine once the incision heals. That's, again, saying, well, fine, you'll be fine. Don't worry about it. You can ask your doctor about cosmetic surgery if needed. Well, there's no cosmetic surgery, first of all, for hysterectomy, and it doesn't meet the immediacy clause, which is saying, let's talk about it, talk to somebody else about it, and it doesn't encourage her to talk to you about it. So A is the only one that meets the 2 therapeutic communication rules, which is immediacy and encourage them to talk about it. Okay? I hope that's helpful to you. Maybe I'll do more therapeutic communication stuff, because I just know a lot of people who struggle with that, including my own students. So I hope you have a great rest of your day, and that you do well on your Nclex when you take it. And our thoughts and prayers go out for you. We want you to pass. So let us know when you do. Thanks for being a part of the Clinic Review family.